Hello everyone, myself Dr. Deepak Patel, third year resident doctor in Government Medical College, Surat. My paper presentation topic is Hypertrophic olivary degeneration, Diagnostic Utility of MRI. I would like to thank Dr. Purvi Desai, Professor and Head of Department of Radiology. We will cover my paper under following headings. Introduction. Hypertrophic olivary degeneration is an uncommon condition marked by a distinct pattern of transsynaptic degeneration. It occurs due to a lesion in the brainstem or a cerebellum that disrupt the triangle of Gillen and Mollaret, also known as the dentatorubro-olivary pathway, leading to hypertrophy of the inferior olivary nucleus. The triangle of Gillen and Mollaret, it is a connection between the red nucleus, ipsilateral inferior olivary nucleus, and the contralateral dentate nucleus. The olive receives the GABAergic signal within the dentatorubro-olivary pathway. Interruption of the either connection between the dentate nucleus and the contralateral red nucleus, or the connection between the red nucleus and ipsilateral inferior olivary nucleus, which is the central tegmental tract, leads to transneuronal degeneration causing enlargement rather than an atrophy of the olives. Isolated lesion of the inferior cerebellar peduncle do not cause hypertrophic olivary degeneration, as anatomically there are no direct connection between the inferior olivary nucleus and the contralateral dentate nucleus. Aim of my paper is to study the imaging finding of hypertrophic olivary degeneration and to look for the causative etiologic factors in the triangle of the Gillen and Mollaret. Method. All the patients were scanned by 1.5 Tesla MRI machine. We researched the radiological database of New Civil Hospital Surat for the patients whose MRI brain scan had radiologically proven hypertrophic olivary degeneration. All the scans were recorded from 1st February 2024 to 20th February 2025. The definition of hypertrophic olivary degeneration used in this study include the presence of hyperintense signal in the inferior olivary nucleus on T2 or flare sequence. The first case, the 52-year-old male patient has previously operated for hydrocephalus, has now presented with slurring of speech, tremor, and impaired balance. We can see hyperintense signal within the medullary olives on both sides, which is T2 hyperintense and a flare hyperintense, which shows no restricted diffusion. Uh, and no any lesion identified in the triangle of Gillen and Mollaret. Hence, this is an idiopathic hypertrophic olivary degeneration. Second case, 46-year-old male patient with known case of IPH and has came with the post-traumatic convulsion, oscillopsia, and gait imbalance. We can see there is a hyperintense signal seen in T2 and flare images on the both side in medullary olives on the both side, uh, which shows no restricted diffusion. The Kifel section of T1 and T2 and flare images shows altered signal intraaxial lesion in the left posterior pyramidian pons at pontomeson-cephalic junction, which is hypointense on the T1, T2 flare and T1 images, which shows intense blooming on the GRE images. So there is a probable insult of the central tegmental tract on left side by old hemorrhagic insult with resultant hypertrophied olivary degeneration bilaterally. Third case, 56-year-old male patient with complaint of speech disturbance and difficulty in walking. We can see there is a hyperintense signal in the left-sided medullary olive on T2 sequence, which shows no restricted diffusion. The Kifel section of T1 and T2 sequence shows there is a well-defined lobulated intraaxial exophytic lesion arising from the dorsal aspect of the midbrain and pons. It shows hyperintense signal on the T2 and flare sequences and a hypointense signal on the T1 images. The lesion shows intense blooming on the GRE images, which suggests the features of the cavernoma. In here, we can see there is a hypertrophied and hyperintense medullary olive on left side, along with the cavernoma. So there is a probable insult of the central tegmental tract on the left side by cavernoma with resultant same side hypertrophied olivary degeneration. Case 4, a 75-year-old hypertensive male patient with prior cerebellar hemisphere and intraventricular hemorrhage has presented with nystagmus and hand tremors. We can see there is a hyperintense signal seen in the right-sided medullary olives. The Kifel section of the same patient, which shows the previous cerebellar hemorrhage and microhemorrhage in the pons, which shows blooming on the GRE sequence. So there is a probable insult of the dentate nucleus on the left side by old hemorrhagic insult with resultant contralateral hypertrophied olivary degeneration. Result: the total of 4 cases of hypertrophic olivary degeneration were studied, 2 of which shows old hemorrhagic residue, one in the dorsal pyramidian pons at pontomesencephalic junction involving left-sided central tegmental tract, the other one in the left cerebellum involving the left dentate nucleus. The third case had the cavernoma at the pontomesencephalic junction involving the left central tegmental tract. The etiology of the fourth case remained idiopathic where no cause could be detected. The case with cavernoma and cerebellar hemorrhage shows unilateral involvement of the medullary olives, whereas the other two cases show the bilateral involvement. This is the pie chart depiction of result of my paper. Discussion. The clinical presentation, the oculopalatal tremor is the most pathognomic symptoms. In other symptoms, we can have oscillopsia, upper extremity tremor, facial, cervical tremors, etiopathogenesis. The hypertrophic olivary degeneration, it is most commonly bilateral, which is 75% in most of the cases. And the main etiologic factors, the idiopathic variety accounts for 45%. The other, we can see ischemic injury, hemorrhage, hematoma, or any space occupying lesion in triangle of Gillen and Mollaret. Imaging feature, MRI is ideal. We can see T2 and flare hyper intense signal in the affected inferior olivary nucleus. The hypertrophy of the inferior olivary nucleus seen in the early phase, and after few years, the swelling usually subsides, but T2 hyperintensity persists, resulting in an atrophic hyperintense olive. Same site red nucleus may also lose the expected normal hypointense signal on SWI image. No contrast enhancement or restricted diffusion is seen. Temporal evaluation, in the first MRI detectable change we can see after the third week, the olive becomes hypertrophied due to neuronal hypertrophy and appears swollen and shows increased T2 and flare signal on the MRI. After a few years, olive become atrophied due to neuronal degeneration, but it shows persistent T2 and flare signals. The differential diagnoses are infarction, demyelination, astrocytoma, and metastasis. Conclusion: in patient with hypertrophic olivary degeneration, hyperintense signal is present on T2 images within the first month after the disease onset and persists for many years or may become permanent. Hypertrophy of the olive, on the other hand, typically appears 10 to 18 months after the insult, and it may be seen as early as 6 months and may disappears by the 4 year. MRI is of utmost importance in diagnosing and assessing the temporal evaluation of the olivary hypertrophy and identifying lesions involving the triangle of Gillen and Mollaret. These are my references, and I would like to thanks Dr. Vinay Sah sir and Dr. Ankit Dumaswala sir for their guidance and the support. Thank you.